right, cool. Last but not least, muscle tone abnormalities, right? So this one, I did pretty good on the first two. I think we got it like 10 minutes, so I'll try and be good. We have some anatomy, as you guys remember, but I'll just sort of focus in on what the highlights, greatest hits, the things you got to know for your quiz and just moving forward. So muscle tone abnormalities. Skip over these. The reason the key terms are here is because they're important. So you should have a good understanding of each one of these key terms, specifically the differences between rigidity, spasticity, and flasticity. Flaccidity, geez, sorry. Okay. Know the definition of muscle tone, that it's sort of a background for contraction. It's an underlying tension that's sort of omnipresent at any point that's giving you a sort of plateau or a functional threshold to elicit contraction. So it's always running behind the scenes. Muscle tone is just that underlying tension available in the muscle prior to its contraction. Here are the challenges, right? The fact that it's hard to assess because it tends to be a little bit subjective and it changes quite a bit with movement. And there can also be differences in the way that muscle tone shifts. So obviously, there's a reason these are red. Know the difference between hypotonicity, which is abnormally low tone, and hypertonicity, which is abnormally high tone, and know the presentations, right? So flaccidity is going to be a hypotonic sort of picture, right? It's going to be a result of hypotonicity. So decreased resistance to stretch. Flaccidity, boy, is the total absence of tone, right? So it's not like muscular weakness, it's a complete absence of tone. You have to think about these in terms of tonal abnormalities. These are not normal things that happen. It's not just that your muscle's a little tight. Know the difference between rigidity and spasticity, rigidity will resist stretch regardless of how hard or fast you push, right? Spasticity has a velocity dependent factor where the resistance to your stretch is going to be higher at high velocities and lower at low velocities. So this will have implications in terms of how we're going to treat spasticity, which we'll talk about. Clonus, please know clonus. And this is an important one. Clonus defined by rhythmic oscillations or beats of involuntary muscular contraction in response to a quick stretch. I showed you the video. Please know this definition. You're going to see it again. Here's a great chart. I say go into Cameron if you can and look at the charts. They synthesize this information very, very well. They're going to tell us what spasticity is compared to what it is not. So take a look at that. Particularly why very often muscle tone gets confused with voluntary muscular contraction or just posture. And while it plays a part in these things, muscle tone is separate and distinct from these phenomena, right? Fluctuating muscle tone. So please know these involuntary movements or dyskinesias. These are going to be asked of you. I've seen these on a lot of board questions. So by definition, understand the difference in presentation between like a chorea, which is a dance like sharp, jerky movement, or a tremor, right, versus balismus or athetosis. So commit these to memory because the board really likes these on their examinations. Here's the difference. He's getting ready to run. This guy's already had a couple beers. He's kicked back and he's chilling after he won the race, right? So here he's in a high tone position. The background energy attributed at the muscular level, his tone is high. It's prepared to perform work and generate power. This example is he's got nothing to do. He's just kicked back. So the muscle tone is very low because he doesn't need to have any level of muscular readiness. All right. Huge, know the differences between quantitative measurements and qualitative measurements. As a result, or typically as a rule, quantitative measurements are going to involve some kind of numerical value or representation of the information being synthesized, right? Or the data being synthesized and interpreted as information. So quantitative measurements are going to be things that we can typically measure numerically, like a dynamometer reading or a myometer reading or isokinetic testing or an EMG. Versus a qualitative measure. And this is not just true for therapy. It's true for any kind of research or scientific evaluation you're going to do. You'll have metrics of quantitative value and qualitative value. So understanding the difference, qualitative value compared to a quant is going to end up being a little more, let's just say, subjective, right? So we're going to use a tonal scale. right? We can use in interpretive scale, we can use a reflex testing or tests like an Ashworth or a modified Ashworth, where it's just a simple measure of resistance during passive stretching. So there's really it's more interpretive. There's really no hard valued numerical result that we can calculate. We're sort of going to interpret what we see, feel with our eyes and our hands to make a determination qualitatively about the state of the patient. So know the difference between those two philosophies. Here's an example of a dyno, right? There's an EMG or electromyography test. This is the modified Ashworth scale. You'll see these on a lot of evaluations. You can see it's fairly simplistic scale. So there's a lot of leeway here. It's not quantitative in the sense that we know exactly to a number, to a decimal, what is going to qualify a certain category of spasticity. But we take what we see and discern it in a way that is going to end up on a grade with this scale. Right. Measuring the muscle tone, again, is not always the easiest thing to do, but you have to, because again, it changes with things like position of the head, lines of gravity. We need standardization of touch, and we have to think about the muscular strength. So there's variables that make muscular tone difficult to read, measure, and interpret, but we do the best we can, and we're trying to put the position of the muscle in an optimal position to be able to get the best, most reliable result we can. So muscle tone, again, here is more accurately measured at the mid-range of the muscle length, very much like your manual muscle testing. Right? You'll get into this with peds. It goes to show that the position of the head and neck can affect muscular tone, especially reflexively. So we have to pay attention. You guys will talk about this in peds, but you have to pay attention to the body position when considering muscular tone. All right. This is going back through the anatomy. Refresh yourself on actin and myosin, the actin-myosin cross-bridge, the power stroke, the length-tension relationship. Remember that most cross bridges are formed at the mid-range of the muscle. This is huge. This is our length-tension curve, length-tension relationship, right? This is the happy place of the muscle, right at the mid-range or optimal length, right? Or just anywhere in the middle of the range. We're going to have the most available actin and myosin cross bridges formed. It's going to be in its happy place. And because of that, its ability to generate strength and force is going to be maximized, right? So think of our curve. Remember our length tension curve. Bring that back. Okay, there's actin, myosin. Revisit some of the anatomy behind that. Okay, important here. Okay, neural contributions. So we know that muscular activation is a dance. It's a dance between the muscle tissue and the nervous tissue. So we get neural inputs, like we talked a bit about with pain, from the periphery, which is sort of the extremities, nerve of the extremities or the peripheral nerves, spinal cords, and the brain centers, right? So like areas within the brain is all going to contribute to the ability to, from an anatomy and physiological standpoint, to be able to generate muscular tone and activation. So the alpha motor neuron is super important to remember, is that final common pathway that's going to directly stimulate muscular contraction. We call that the alpha motor neuron. And it helps to generate, summate, and conduct an activating signal. And the sole purpose of the alpha motor neuron is to facilitate muscular contraction. It works alongside the muscle tissue. It intertwines with the muscle tissue in a way that won't take you too far back to the physiology, but in a chemical and electrical way that's going to be able to stimulate and facilitate muscle contraction. So this brings it all together. We talked about the dorsal root. We talked about the afferent pathways, sensory pathways, specifically of pain last lecture. Okay. Now we're talking about the motor neuron. The motor neuron is going to be the efferent pathway, or the pathway that conducts impulses away from the spinal cord, where afferent pathways conduct sensory information to the level of the spinal cord and then perhaps up to the brain, right? Efferent pathways are going to conduct information or impulses away from the spinal cord, and they will be motor in nature, okay? So sensory is input or afferent, motor is output or efferent. Right? That's huge. Just know that fundamental basis. So in our example, right? We get stimulation from the sensory receptors. Here, the free nerve endings of this patient's or this example's forearm. That information travels up through the dorsal component and into the dorsal root through the dorsal ramus of that nerve, right, of the spinal nerve. It's interpreted at the interneuron, right? At that point, some information will be directed to the brain for processing, but other information may be directed back down at some point initially, depending on whether it's reflexive or it's interpretive at the level of the brain, right? Either way, once we have a marching order or information about what needs to come next from a motor perspective, the efferent pathway is going to distribute that new command or that information through the ventral root or the front of the axon of the motor neuron. Here we go. This is down through the front, out through the spinal nerve, and at the neuromuscular junction, which is the junction essentially between the nerve, like the end of the nerve, and the muscle itself, and it's going to stimulate that nerve to elicit a contraction. I mean, very simplified breakdown of it, but I don't want to get too crazy for the purposes of this lecture lab. We will discuss this all through your program, I promise. So here's the structure and the functions of nerves, knowing that the dendrites are responsible for receiving information while the axons are the ones that are actually conducting stimulus. Signals are conducted across the synapse through neurotransmitters. You'll see a picture of this in a second. There's a depolarization and repolarization process that's going to be initiated by sodium-potassium pumps. This is way back to your physiology. Please look that over. I'm not going to spend a lot of time reviewing this, which basically just has a polar change or changes the charge of the neuron and creates a wave of activity. That's how we generate the action potential, and that's what the action potential is. It's the depolarization and repolarization, right, from these elicited from these neurotransmitters, executed through the sodium-potassium pump to create a wave of activity. That's the action potential, right? And then transmission. Obviously, we know that transmission in nerve structures that are myelinated or have that conduit of myelin are able to transmit speeds of action potential much, much faster than unmyelinated. So think of your A delta fibers versus your C fibers, right? So here's the synaptic cleft, right, the synaptic divide. Here are your packets of neurotransmitter. Here in this example, the synapse is at rest. The synapse becomes activated. The neurotransmitter is released and aligns with receptors on the muscle itself to initiate the process of action potential and start to impact the depolarization and repolarization of the process of the essentially of the sodium-potassium pump, right? So this is how it all gets started. Again, go back to your A&P if you need a review on that. Sources of neural stimulation, we're going to get inputs from the periphery, right, through the form of peripheral inputs of muscle spindles, Golgi tendon organs, things like cutaneous receptors. We have spinal inputs, and we have supraspinal inputs, which are basically going to come from above the level of spinal cord, right? Sensory motor cortical contributions from the cerebellum of the brain, basal ganglia, limbic system, so from the brain and specifically the brain stem. All right, so here's a muscle spindle. Consider muscle spindle as a 1A sensory afferent neuron, right? 1A, so if first line, it's a afferent neuron that's going to conduct impulses towards the spinal cord, right? Up towards the spinal cord. And it's going to be responsible for sensing muscle lengthening, right? This is the sort of the stretch reflex. It senses muscle strengthening or lengthening, excuse me, and it's going to signal to contract the associated muscle fiber, right? If you're falling asleep in class and you put pressure on the muscle spindles and it senses a lengthening moment in those muscles to some degree, it will activate those afferent pathways and give information that says, hey, we need to contract this muscle because we're overstretching. Golgi tendon organs are also would be a 1B sensory afferent neuron that's going to still, again, conduct information or impulses towards the spinal cord. But the information it's going to conduct is about continuous feedback with regard to the level of muscular force. So it's going to give us feedback about, to some degree, about recruitment, necessary recruitment, right? How much force do we need to elicit a certain amount of contraction to accommodate a certain amount of work, right? So it's going to kind of regulate to some degree the level of muscular force based on need most of the time. All right. They when we get input from the periphery, it's usually a fairly unmodulated, pretty predictable sort of stereotypical motor response. When we have a single stage sensory and motor neuron, so one single sensory and one single motor neuron, a very simplistic sort of afferent and efferent reactive phenomenon, right? So one sensory input resulting in one motor input, or one motor output, I should say, is going to be termed a monosynaptic reflex. And this is the result from a sensory input that is able to occur and cause a motor response because of the inner neuron, right? So we don't have to wake up the brain or the brainstem or a higher level supraspinal process in order to elicit certain contractions, because that would just be exhausting. So something like a monosynaptic reflex, right, would end up being like a patellar reflex, right? The body knows what to do with this. It's a very simple reaction. It has one specific pathway that it can travel down, and its interpretation is simplistic in the sense that we don't need to trouble the brain with this information. We can take this afferent 1A spindle signal, right, send that impulse up to the spinal cord. It's interpreted solely at the level of the inner neuron. The spinal cord says, oh, okay, this is no big deal. This is just a reflex. We know what to do with this. The inner neuron will process that information and send down the corresponding motor neuron signal or impulse, right, efferently down to the quad, and the result is your leg kicks out or you have an extension moment at the knee. Right? So there's an immediate response with no need to evolve the brain. So we don't need to wake up the boss for this. This is business as usual. It's a simplistic stimulus and response phenomena. Reciprocal information, so that's a very simplistic version, but we also have some other examples of how this works from an afferent and efferent perspective. So reciprocal inhibition will end up being a PNF pattern that we learned, but in essence, it's when the agonist muscle fiber is stimulated, the antagonist muscle unit or motor unit has to be inhibited to allow for motion to occur. So in this example, in order to contract my bicep, I don't just need a motor impulse that's going to stimulate the bicep to contract. That's one half of the equation, right? I certainly need that impulse that will stimulate bicipital contraction, but I need a concurrent signal that will be sent to the triceps to stimulate that muscle to relax, to allow for range of motion into the elbow flexion I'm trying to perform. So what happens? I get a signal, an afferent signal. There's a 1A afferent signal sent from the biceps that says, okay, we need contraction. Sent up here through the dorsal horn, through the dorsal ramus, dorsal horn, afferently, interpreted by the inner neuron, and we have a two-way communication from a motor perspective efferently. We have a positive, like a switch-on moment, or an excitatory moment that is going to be sent as an impulse down to the bicep to encourage that action potential and the creation and cultivation of the contraction of the biceps, right, for the agonist for this movement, which is elbow flexion. We're also going to have an inhibitory impulse sent down still efferently from the ventral horn and the ventral ramus down to the opposing muscle, the antagonist, to the triceps, and that signal is going to encourage the triceps to switch off or inhibit itself or find a relaxation moment to allow relaxation of the tricep so the bicep can take over and perform elbow flexion. We see this again with some other sort of reflexive responses. We have cutaneous receptors at the bottom of the foot, and everybody's done this. My example was stepping on a child's toy in the middle of the night when you're trying to go to the bathroom, right? You step on the Lego, you're like, oh God, what was that? It hurts. So flexor withdrawal or a crossover extension. So it's a two-phase process here. I step, and let's just pretend she's up in the middle of the night. She's going to get a snack, and she steps on something that doesn't feel good. Right? We're going to have excitation of the muscles from the sensory input to allow for a twofold response, which would be flexion of the stimulated lower extremity while also allowing for activation of the extensor muscles of the other side, or the contralateral lower extremity. So how does this work? I step on my Lego, right? Ow, that hurts. I need to get my foot up and away from the pain. I'm going to need a flexor moment, right? That's going to involve the hamstrings. here's our sensory information telling me, ouch, we stepped on a Lego, it's no good. Now from here at the level of the, again, afferent, posterior side of the spinal cord, right, dorsal horn, comes to the level of the interneuron, is interpreted and said, oh gosh, okay, we got to get this foot away from the Lego, right, to take us away from the pain. So we will stimulate the flexors of the knee, which are the hamstrings. So we get a positive response here, a positive impulse, an excitatory impulse to flex the hamstring and flex the knee as a result. We also get an excitation of the quadriceps on the contralateral side to stabilize us, because obviously if I don't have an extension moment on the contralateral side when I have a flexion moment, I'm going down, right? So I need an extension moment, which means activations of the quadriceps through these alpha motor neurons that tells me to extend the contralateral leg so I can flex the leg away from the painful stimulus. So there you go. Why is this all important? Well, any physical agent, right, or therapeutic modality touching the skin has an impact on muscle tone, right? So we have to understand, we learn about muscle tone because we're going to affect muscle tone using some of the physical agents we'll learn in this class. So consequences of muscular tone, sorry, this is a little bit of a longer lecture, but I'm doing the best I can. Consequences of the muscle tone here are variable, right? We have alpha motor neuron damage. We can end up with low muscle tone. You can give a hypotonicity example, right? Which usually happens from alpha motor neuron damage, which is largely peripheral. And that usually results in hypotonicity or flaccidity to some degree. So here's low muscle tone, which is insufficient excitation of the alpha motor neuron, and we're trying to increase the tone. And this can be from a neuromuscular disease process, a neurological disease process, trauma or compression on a nerve, right? So here are a few things you might do for that. Here are some of the rehab processes or rehab modalities or physical agents we can, and therapeutic agents we can affect low muscle tone. High muscle tone is usually coming from a central nervous injury or a higher level neurological dysfunction like a stroke or multiple sclerosis or a traumatic brain injury. So you have a normally high excited port input. Know these, okay, and know the associated effects. Know these and the associated effects and what we do to address them, okay? So here are some things that we might start to look at. Spinal cord injuries start out flaccid, and they're followed by spasticity. Here are cerebral brain lesions, which are lesions of the brain, which lead to, sometimes are caused by these disease processes, and these are how we manage them. The difference between spasticity and rigidity, also understanding the two postures that are attributed to certain levels of injury at the spinal cord or at the brain. So here's a decorded posture and a decerebrate posture. It should be here and here, right? The only difference between these two postures and how they present is going to have to do with where in the brainstem we end up with our damage or our lesion. So an upper level brainstem, you'll talk more about this in neural component, upper level brainstem damage or lesion will result in this flexion-based posture we see here, right? This is the decorded posture. Decerebrate posture is going to be a lower level lesion, right? An indication of a lower level brainstem lesion. So we'll see these extension moments at the upper extremities. This is what we call a decerebrate posture. So understand those. If you need a synthesis of the interventions that we use primarily for low muscle tone or high muscle tone, broken down by pathology, look at Cameron, right? Go into your book or your online textbook, and there's a really great couple boxes that will give you information about how each one of those is going to present based on pathology, as well as the corresponding modalities that we might use to affect these. So, sorry guys, went a little bit longer on this. Know the difference between low and high muscle tone. Know these different postures and where they correspond to the brainstem. Know the definitions and presentations between spasticity and rigidity and where they come from, right? High muscle tone examples. Know some of the fundamental components of spinal cord injuries and cerebral lesions. Here, understand that these are the associated effects, and these are how high muscle tone may present. So know what causes high muscle tone, where it can be caused in the brain or the spinal, mostly in the brain, and how it presents and what it looks like and how we address it. The same thing for low muscle tone. All right, these are the examples. Know the difference between your afferent and your efferent pathways, what they do, which one's sensory, which one's motor, where in the spinal cord they're interpreted, how they can be interpreted at the interneuron. Difference between a GTO, cutaneous receptor, and a muscle spinner in terms of the inflammation that they present. Not so worried about that. Understand the definition of action potential. Same deal, just start to piece together the process of afferent and efferent signals, how they're interpreted, and how they can elicit motor response through the alpha motor neuron. Know what the alpha motor neuron is. Know that it is the sole purpose of the AMN is to facilitate muscular contraction, and that it's the final pathway that directly stimulates muscle. Cross bridges, mid-length, length-tension relationship. Remember this stuff. Go back to your anatomy. How do we go about measuring muscle tone? The difference between these quantitative and qualitative measurements. Fluctuating tones in terms of their dyskinesias or their involuntary movement. Definitions of hypo versus hypertonicity. And clonus, rigidity, flaccidity, spasticity, and clonus. Know those. Cool. That's it. All right. Got this one under 30. That's actually pretty darn good. Sorry it's a little bit longer, but there are some more complex concepts that may not show up necessarily on your quiz, but the sooner you can start to commit these to a working understanding, the easier it's going to start to be to tie these into your pathology and your understanding, sort of diagnostically of pathologies, and prognostically in terms of what goals may be set for this patient, and most important, interpreting what appropriate interventions we as LPTAs are going to be responsible for, how we progress them, how we regress them, and how we move the patient forward towards achieving their functional goals and restoration of ADLs and quality of life. Good job. Thank you for bearing with me, guys. That's all the PowerPoints for this week, so hopefully that was useful, and I will see you all on Monday. Study hard. Quiz on Monday.